Alright, in this audio I will begin with non-surgical management for colorectal cancer. With non-surgical management, we can provide radiation therapy and we can provide chemotherapy. Radiation therapy is typically providing a local control of the disease. Radiation can be used to control obstruction from the tumor. It can be used to control metastasis to the lung. It can be used to control any hemorrhage or bleeding, as well as pain. Now, some side effects of radiation are diarrhea and fatigue. Chemotherapy is typically recommended for patients after they've had surgery and for patients with stage 2 or stage 3 disease. Now, keep in mind that chemotherapy drugs cannot tell a difference between healthy cells and cancer cells, okay? Side effects are diarrhea, mucositis, leukopenia, mouth ulcers, and peripheral neuropathy. Now, surgical management, that involves colon resection or a colectomy. Now, we have to remind these patients and be very supportive because the patient's physiological change and their function will change drastically, okay? There's a very strong possibility with colostomies for colon resections. Now, most oftentimes patients who have lower rectal surgery, they're faced with the risk for postoperative urinary incontinence and sexual dysfunction. Now, we want to make sure we're discussing that the surgeon is discussing the risk for these problems with that patient, okay? We as nurses should not be answering questions about the surgery for the patient, okay? That should be the physician or the surgeon's responsibility, but it is our responsibility as nurses to teach them, what a colostomy is, how it will affect our appearance, how it will affect our function, okay? It's important for us as nurses to teach these patients about patient-controlled analgesia, okay? They'll have a button that they can push which will send pain medicine to their IV, okay? It's also a good idea to keep in mind the patient's and family's level of knowledge and their education level. We want to make sure that there's support available to the patient, okay? We want to make sure our patient is being involved in meaningful hobbies or activities. We need to make sure that the patient can actively care for themselves if they do not have someone else to help them, okay? Now, IV antibiotics are typically given before the surgery. NG tubes are typically placed after surgery for decompression of the stomach, okay? Now, when a colon resection occurs, there is an anastomosis of the colon, okay? Now, if anastomosis is not able to be made, then a colostomy is created. Now, colostomies can be temporary or they can be permanent. And colostomies can be created in the ascending, transverse, descending, or sigmoid colon. The stoma is a surgical opening, and that's when a piece of the colon has been brought to the surface of the abdominal wall, okay? I don't want you to worry about the different types of colostomies as far as the end, the double barrel stoma and the loop colostomies. I just want you to focus on the ascending, transverse, descending, and sigmoid colon in terms of how would the stool be with a right-sided or an ascending versus a sigmoid colon or a left lower. Now, the healthy stoma, it should be reddish pink, should be moist, okay, shiny, and it should protrude from the abdomen about 3/4 of an inch, okay? Now, right after surgery, that stoma will be a little bit swollen, and a small amount of bleeding is common, okay? 2 to 3 days post-operatively is when we should start to see a function in that colostomy. Now, we want to make sure that we're emptying that colostomy when it's 1/3 to 1/2 full, okay? We never want to let that colostomy get over half full, okay? Now, drains can be placed. We want to teach our patients about the drains that can be placed. Now, drains help to prevent drainage from collecting in the wound, okay? So a lot of times patients may have drains, and then rectal pain and itching can occur after healing, okay? So it's important to provide these patients with perineal wound care. There's a chart 56-3 on page 1154 that goes over perineal wound care. I'll let you read over that. Now, keep in mind that these patients, whenever we're assisting them with their grieving process, we have to remember that normal responses to a body function change are sadness, denial, depression, anger, okay? We want to make sure that we can help these patients cope with these new body functions, okay? We want to make sure that the patient is participating in their colostomy care if they are able, okay? We want them to verbalize their feelings and identify their fears, okay? Now, typically the patients for colon resections are in the hospital until they have a bowel movement. These patients are not allowed to eat until they have resumed bowel sounds or passing gas, okay? Now, with the NG tubes, now we won't take the NG tube out until we are absolutely sure that it is okay to take out. A lot of the times what the physician will have you do is to clamp the NG tube or unhook it from the suction and have the patient get up and move around and see if they are becoming nauseated, okay? If they're becoming nauseated, that probably means we need to hook them back up to suction. Now, we want to make sure these patients are avoiding lifting heavy objects, and we don't want the patient to have any tension on their anastomosis site, okay? For those that have colon resections and they do not have a colostomy, we want to make sure that we prescribe, the surgeon has prescribed them some sort of laxative or stool softener to go home with, because we don't want these patients straining for defecation, okay? Now, we don't want to give those in the hospital because we want the patient to actually go in the hospital. We want to make sure everything's working correctly without any help. Now, we want to make sure this patient's avoiding driving for 4 to 6 weeks while that incision heals. As far as colostomy care, it's important to teach the patient that the stoma can shrink within about 8 weeks after surgery. So whenever they're measuring the wafer for the appliance and to go over the stoma opening, it's important that they measure at least once weekly, okay, during that 8 weeks post-operative time. Now, it's important to stress the appearance of what the stoma should look like, the normal appearance of the stoma, okay? Pink, red, moist, shiny. We want to know of any signs and symptoms of complications, okay? We want to make sure they're measuring the stoma. We want to make sure they are using the appropriate devices to cover the stoma. We want to make sure that they are protecting that peristomal skin, okay? We can teach them about nutrition changes to help control gas and odor, because gas and odor are a big issue for patients with colostomies. So broccoli, beans, spicy foods, onions, mushrooms, those can all cause gas, as well as chewing gum, drinking beer, smoking. Crackers, toast, and yogurt all help to prevent gas. Now, as far as odor, buttermilk, cranberry juice, parsley, and yogurt can help prevent odor, okay? A breath mint in the pouch can help with odors as well, but we want to make sure these patients aren't putting any aspirin tablets inside their pouch, okay? Just keep in mind that psychosocial concerns for these patients, they are fearing not being accepted by others. They are concerned about their sexuality, okay? They can resume normal activities. They can resume sexual intercourse. They can resume work after cleared by their physician, okay? If you'll take a look at chart 56-4 on page 1156, it's titled The Patient with the Colostomy. And if you'll just read over that. In the next audio, I will begin with intestinal obstruction.